Okay, welcome everyone. I'm Lynn Chang, and I am going to moderate the functional GI disorders session. We're going to do 2/3 before lunch, so we are running about 20 minutes behind, but our lunch will be served when we get there. And then we'll come back after lunch and we'll do about an hour. So we are going to move from a testosterone-driven session to an estrogen-driven session. But we have some testosterone on our panel here. And I'm not talking about me, I'm talking about Bill. Okay, so this is the overview. We're going to use some didactic lectures, and we're also going to have some case-based presentations, but it's really to just set up scenarios that we can discuss. And then we're going to have some panel discussion. Hopefully we can keep it all within time. And this is what we're going to review today: the dietary management in IBS, avoidance restrictive food intake disorder in GI disorders, diagnostic assessment of chronic abdominal pain, pharmacologic treatment of chronic abdominal pain, non-pharmacologic treatment of functional GI disorders, diaphragmatic breathing, and you're going to get a demonstration of that, to treat GI conditions, and behavioral therapies. So I want to introduce our panel. So actually I had notes, but okay. So from UCLA, we have Lynn Connolly, who's a gastroenterologist and the clinical chief of the community clinics. And then we have Christina Gentile, who's our GI health psychologist, Janelle Smith, who's a GI registered dietitian, Suzanne Smith, who's a nurse practitioner and also an integrative health practitioner, and Kirsten Tillisch, who is the chief of the integrative medicine. I know I probably didn't get it completely right, and also works in our center at UCLA, the Oppenheimer Center for Neurobiology of Stress and Resilience. And our token male today is Dr. Bill Chey, who is my esteemed colleague and good friend, and you probably all know of him or know him personally. He's given a lot of lectures. He's an expert in our field, internationally known, and he's from Michigan Medicine, and one of his areas of interest is food and nutrition in GI. Okay, so I'm going to start with a patient case. This is a 26-year-old gentleman with a history of abdominal pain who has diarrhea since college. Abdominal pain occurs 2 days per week and is associated with 3 to 5 loose stools and urgency. He feels, quote, constipated and bloated about 1 day a week when he either doesn't have a bowel movement or has a hard, small stool. He has no alarm features like bloody stools or unintentional weight loss, family history of organic disease. He sleeps pretty well, except when his symptoms are more severe. Symptoms sometimes impact his work productivity at his school productivity. He's a grad student, and also going out socially. And he admits that stress can exacerbate his symptoms. He's had a number of diagnostic tests that includes celiac serologies, CBC, comprehensive panel, and fecal calprotectin. He tried a dairy-free diet and then tried a gluten-free diet. There was some limited efficacy. He avoids antidiarrheals because he feels that it gets him more constipated. So this may be a common scenario that you've seen in your patients. So I'm going to ask the panel, what do you think the most likely diagnosis is? Lynn, what is your...
Sure. So it appears that he meets the Rome 4 criteria for irritable bowel syndrome, diarrhea predominant.
Okay. And we're going to go over some of that workup. What would the panel think about the next step in management, and specifically, when would you start a low FODMAP diet? But let me ask you, Bill, like what are you thinking as far as the management approach?
You sure you want to hear from me? Because that's exactly what I'm going to talk about in a minute.
The low FODMAP? What other options do you usually use in these kind of patients other than diet?
Yeah, in this patient in particular, thinking about behavioral strategies sooner than later might also be a really valuable exercise. I'm finding that our center, just like UCLA, is taken very much a more integrative approach between diet strategies, behavioral strategies, and medications. And it's not uncommon that I utilize all three really coming out of the box. So this patient would clearly benefit from a more organized strategy in terms of diet modification, and that might utilize some of your GI or dietitians. Behavioral strategies, I think, would be very helpful, and maybe some PRN medication.
So if you're going to refer a patient to the GI dietitian for a dietary therapy, do you start either PRN medications, or do you start a medication, while you're waiting for the appointment and getting going? What's your strategy?
Yeah, it's interesting because it really varies by the individual. The nice thing is we have the full suite of different menu options, and it really is a matter of negotiating with the patient to choose the right combination of menu options for that specific patient. There are many patients that come in and want nothing to do with significant dietary modification. On the other hand, there are many patients that want only dietary modification. So it really depends upon the desires of that individual patient. And we presented an interesting study last year that showed that, for example, given a choice between antibiotics and diet therapy and IBS-D, older patients almost exclusively choose antibiotic therapy. Younger patients almost exclusively choose diet therapy.
Yeah, it's interesting. So, Janelle, for you, when you see a patient, do you immediately think about the low FODMAP, or what is, because I don't think every dietitian does that. What is your approach?
For IBS-D, I do think of the low FODMAP diet from the start, but I'm also going to screen for contraindications to the low FODMAP diet, even if it's been recommended by the physician. Do they have limited access, limited means, food insecurity, eating disorder risk, etc. But I will also use other strategies such as L-glutamine, soluble fiber. I also ask the patient, how do you want to manage it? This is kind of your options that we know based on evidence.
Yeah, so if they're going to come see you, they're obviously interested in diet, but of the diet recommendations, you give them options. Yeah, so I guess that's a good partnership strategy. Okay, since I know we're running late on time, so I'm going to go ahead and go through to our first lecture. And you're going to hear two lectures really more focused on diet. And the first one is by Bill Chey on exclusion diets for IBS.
Well, thanks very much, Lynn, and it's wonderful to be the token male on this panel. I don't think that's ever happened to me before. I was just looking at some statistics from Medscape, literally just within the last couple of days. You may have seen this survey, but we're at 20% women in gastroenterology overall. So this really is sort of a reversal here on this particular panel. I'm going to talk about exclusion diets and dietary therapies in general for patients with IBS, and I don't think we need to go over the definition of IBS. Remember the key features: abdominal pain and altered bowel habits. And the confusing part is the bowel-related phenotype can be quite variable. Some patients with diarrhea, some patients with constipation, some patients with that mixture of both diarrhea and constipation. And as we go through this, a lot of these diet strategies focus more so on the IBS-D than IBS-C, although there's emerging data to suggest that at least for abdominal pain and bloating, you may be able to employ many of these strategies even in the IBS-C patients. So remember that in regards to the pathogenesis of IBS, the thoughts around the pathogenesis of IBS have been rapidly evolving, and more we're focusing on the interface between what's happening in the lumen of the GI tract, the luminal microenvironment, which is composed of so many different things, but some key things: food, the microbiota, as well as a variety of different mediators and chemicals, like bile acids, for example, neurotransmitters released by neuroendocrine cells. And that interface with the luminal microenvironment with the immune system in the mucosa and submucosa. And of course, the interface is the permeability of that gut epithelium. So it's critically important that what's in the luminal microenvironment and how it interacts to activate those enteric neurons, which influences motor function, sensation, and of course, cognitive emotional function, brain-gut interactions. We know that food is really important, okay, and to IBS patients. We know that because multiple surveys have shown that IBS patients identify food as one of the most important triggers for their GI symptoms. And despite what I was taught back in 1990 when I was a GI fellow, that fatty foods were the biggest culprit, it turns out that IBS patients say that the biggest culprit for them is actually carbohydrates. Now, fatty foods are important for some patients, but carbohydrates are the most commonly cited culprit foods in IBS patients. Now, the good news is if you survey U.S. gastroenterologists, as we did actually, Adrian Lenhart, who's now joined the GI fellowship at UCLA, worked with me at Michigan for a number of years before coming out to LA. And in a survey of around 1,500 U.S. gastroenterologists, we actually found that 3/4 are recommending diet therapy or diet modification to at least half of their IBS patients. So this is pretty ubiquitous amongst gastroenterologists across the United States. And a really surprising statistic from this survey was that U.S. gastroenterologists think that diet therapy is as good or better than the other treatment recommendation or treatment options available to you. So diet, again, has really permeated our management strategy of patients with IBS. And we'll talk about what are the evidence-based diet strategies in just a moment. Now, this slide gets very precisely to the question that Lynn asked. What do you do? Well, if you think about at the bottom of the pyramid, patients with mild symptoms, diet, lifestyle modification, I really think should be the first thing that you think about. Okay, you don't necessarily have to utilize those things in every patient, but you should consider that possibility and discuss those options with the patient, find out what his or her desires are in terms of the way they want to approach their symptoms. What you'll find, and I know all of you know this, some of the patients will want a medication. They'll just want you to prescribe something for them. Other patients will want nothing to do with medications and will want you to tell them how to modify their diet or lifestyle in a way that helps them to self-manage their symptoms. For patients with more moderate or severe symptoms, you're going to start to bring into play things like prescription medications, neuromodulators, as well as some of the alternative techniques that we'll talk about as we get into this program. So let's talk about the evidence as it currently exists relevant to various diet therapies for patients with IBS. For the sake of time, I'm only going to be able to review a gluten-free diet and a low-FODMAP diet, but there are other diet strategies which we can certainly talk about and touch on during the question and answer period. In this first slide, and we'll start this discussion of a gluten-free diet in patients with IBS, just to make this point. While the prevalence of celiac disease has remained quite stable over the last 5 to 10 years at around 0.8%, by the way, it's a good number to commit to memory, the point prevalence of celiac disease in the United States is around 0.8%. The proportion of individuals without celiac disease who self-report taking a gluten-free diet or consuming a gluten-free diet has linearly increased. Actually, in this time frame over the course of 4 years, it almost doubled in that amount of time. Now, it is starting to level off, but the number of individuals taking a gluten-free diet that don't have celiac disease now dwarfs the number of individuals utilizing a gluten-free diet for actual diagnosed celiac disease. And we're learning more about this population of patients with so-called wheat intolerance or wheat sensitivity. I'll talk to you in a moment why that's a better term than gluten sensitivity. In fact, I don't think we should be using the term gluten sensitivity anymore until we get biomarkers that really help us to identify the patients that have symptoms as a consequence of consuming gluten. If you look at this study from Australia that was recently published in the Red Journal, first thing is what's striking, 14% of the individuals that answered this survey reported some intolerance of eating foods containing wheat. In addition, the symptoms associated with these individuals reporting wheat intolerance look exactly like IBS: abdominal pain, abdominal discomfort, bloating, altered bowel habits. And in fact, it turns out that IBS and functional dyspepsia are both much more commonly present in individuals reporting so-called wheat intolerance than in healthy controls. So what is the evidence to support a potential role of a gluten-free diet in patients with IBS? Well, right now, you'd have to conclude that there's not a lot of evidence. Now, I want to preface that by saying that doesn't necessarily mean it doesn't work. It just, the only thing we can really say right now is we don't really know whether it works or not. In this meta-analysis that we recently published in the Red Journal, 2 randomized control trials containing a whopping total of 111 patients, so these are very small studies, came to different results. One actually suggested potential benefit. The other one found absolutely no benefit whatsoever. Bottom line is that when you amalgamate that into a meta-analysis, there was no statistically significant benefit offered by a gluten-free diet in patients with IBS. But I think you'd agree that the jury's probably still out on this question. I think that right now we really don't have robust data to help to guide us as to whether or not this is useful or not. I think it's very important to remember that there are multiple reasons why wheat might cause symptoms in patients with IBS. So we all know about gluten, the storage protein that can lead to immunological activation in some individuals with IBS, and perhaps that's a reason for development of symptoms. But remember that wheat is the most fertile source of dietary fructans in the Western diet, and dietary fructans are part of the FODMAP family. They're short-chain carbohydrates that your small intestine cannot digest or absorb. So fructans that you consume in wheat will universally get to your distal small bowel and colon and will be fermented by bacteria that reside there, producing gas and short-chain fatty acids, which can trigger symptoms in patients with IBS. It's also important to remember this concept of nocebo response. You're all very familiar with the placebo response, this idea that if you believe something's going to make you better, it will. The nocebo response is the opposite and is equally operative in circumstances where somebody really thinks that eating a food, for example, will make them worse. They're more likely to develop or sense or perceive adverse symptoms in association with eating that food. So this is a diverse set of individuals that develop symptoms in association with eating wheat. Fructans, nocebo, as well as gluten or ATIs, other proteins. So a better term is wheat intolerance or wheat sensitivity as opposed to gluten intolerance. All right, let's move to the low FODMAP diet. Now, remember that FODMAP is an acronym that stands for fermentable oligo monosaccharides and polyols, which are short-chain sugars which your small intestine has difficulty or simply can't digest or absorb. And for that reason, FODMAPs are available to the bacteria in the distal small bowel and colon and lead to fermentation, which produces gases and short-chain fatty acids, which can trigger symptoms in patients with IBS. There are now multiple randomized controlled trials which have evaluated the low FODMAP diet versus a variety of different types of comparators in patients with IBS. In fact, we published this meta-analysis about a year ago now, and there were 7 randomized controlled trials that fulfilled our entry criteria. There's now probably 9 or 10 randomized controlled trials evaluating the low FODMAP diet versus a high FODMAP diet versus a habitual diet versus usual dietary recommendations. So the comparators are very diverse. The studies are generally small, and you can imagine that it's almost impossible outside of providing all the food to a patient to really blind these studies. So the evidence, the quality of the evidence, has been graded as very low. Taking all of that into consideration, if you do this meta-analysis, as we did, what you find is that there is a statistically significant benefit of the low FODMAP diet for overall GI symptoms in patients with IBS versus these comparators. In particular, there's benefits for abdominal pain and bloating, but also for diarrhea in some of the studies. It's really important to remember that if you're utilizing this diet, it's best done in collaboration with a GI dietitian, and you must do all 3 phases of the diet plan. You should view this not as a diet, but as a diet plan consisting of 3 separate and distinct phases. The first one is elimination or restriction. That really only needs to last for 4 to 6 weeks. If a person does not respond to that restriction within the first 4 to 6 weeks, you abandon the low FODMAP diet and move on to some other strategy. I want to say that again. If a person does not get better, you do not leave them on the diet. You take them off of the diet and move to another strategy. If, on the other hand, they experience at least some improvement, you go through a reintroduction of foods containing individual FODMAPs to determine a person's sensitivities and use that information in the 3rd phase of the diet plan, the personalization phase, where you allow the individual to liberalize their diet on the basis of the information that you gain from that 2nd phase of the diet plan. please don't do this diet unless you're doing all 3 phases. And please, in particular, don't view elimination as the diet plan. It is not. Elimination or restriction is the beginning, not the end. It should be viewed as a diagnostic test to determine whether somebody goes on to additional work with this diet plan. If they don't respond, take them off of the diet and move on to something else. Well, what's happening in this space? I've told you now that there is, I think, persuasive evidence to suggest that restriction of FODMAPs leads to symptom improvement in a significant proportion of patients with IBS. I would say around half of the patients with IBS get better with dietary FODMAP restriction. We realize that the low FODMAP diet has very tangible impact upon the gut microbiome. There are now multiple studies, probably 4 to 5 different studies, all showing that restricting FODMAPs, remember that FODMAPs are really important prebiotics for the bacteria that live within the GI tract. So if you restrict FODMAPs from the diet, a couple of things happen. First one is you get a relative reduction in the absolute number of bacteria that you can identify in the colon, and there's modification of the constituents. One thing that's raised some red flags is a reduction in bifidobacter-containing strains in association with FODMAP restriction. That's been found in a number of different studies. The good news is, though, that there's very interesting data to suggest that you may be able to leverage information about the microbiome to identify individuals more likely to get better with the low FODMAP diet. So think about this. Might it be possible to profile the colonic microbiome, the stool microbiome, before an individual goes on the diet and identify which individuals are more or less likely to get better with the diet? The answer from at least 4 preliminary studies is maybe, is perhaps. Okay, so this is data from one of the most recent studies that have tried to utilize microbiome as a way of enriching the likelihood of response to the low FODMAP diet. 61 individuals from Norway with moderate to severe IBS. And just like our study from the United States, 52% got better with the low FODMAP diet. They collected stool samples and did 16S analysis before the diet intervention and found that characteristics of the microbiome in that pre-treatment stool identified the patients who were most likely to respond to the low FODMAP diet. This has now been replicated, or similar results have been published from Sweden, from the United Kingdom, from Australia. So now, it'd be wonderful to stand up here and be able to tell you exactly what the features were in these studies, whether there was some silver bullet profile that identified patients that got better. Right now, all 4 studies report different characteristics that were predictive. Not surprising, given the fact that these are studies done in different parts of the world, with different genetics, with different diets, but it offers this possibility. The idea of being able to leverage the microbiome as a biomarker to identify patients more likely to respond. And in fact, it may even be more profound to consider the possibility of utilizing the metabolome, the gut metabolome, as a means of identifying patients that respond to the low FODMAP diet. So in this study from the United Kingdom, they actually utilized volatile organic compounds measured in headspace gas collected above stool from individuals that went on the low FODMAP diet. So again, before the individuals got this intervention, they collected stool, they collected headspace gas above the stool, and they measured these volatile organic compounds, which reflect the metabolic activity of the bacteria in the stool. And what they found was that the VOC patterns almost perfectly predicted individuals who responded to the low FODMAP diet. So now we have 2 examples, one leveraging the microbiome, this one leveraging the metabolome as a means of enriching the likelihood of response to the diet. So going from 50%, hopefully up to 70, 80, 90%. In addition to that, another thing from this study that doesn't get discussed very much is that in addition to identifying individuals that responded to the low FODMAP diet, This strategy, measuring VOCs and headspace gas from stool collected before the intervention, also identified individuals who responded to a probiotic. Why does that matter? It matters because if this turns out to be true, it suggests that leveraging the microbiome or leveraging the metabolome may be a robust strategy, a robust biomarker strategy for any of the microbiome-based treatment strategies. So whether you're talking about prebiotics, probiotics, antibiotics, diet, these studies open the door to the possibility of creating biomarkers based upon the stool microbiome or metabolome. So a long ways to go before it's ready for your offices. In fact, you may even be dealing with companies that are making claims about being able to profile the microbiome and do this and that and the other thing. Right now, the literature is not there yet, in my opinion. Again, that might be something worth talking about during our panel. So some key things to think about as you utilize the low FODMAP diet in clinical practice. I think first and foremost, remember those 3 phases. Remember, restriction or elimination is the beginning, not the end. Utilize a GI dietitian if you have that resource available to you. They have more time, frankly, they have more knowledge than we do as gastroenterologists. They can help you tremendously in terms of implementing the diet correctly and making sure that a person does this in a medically responsible way. In fact, in addition, remember that we'll be talking about the emerging role of eating disorders in GI conditions, particularly as we utilize elimination diets. And dietitians and behavioral therapists are much better at picking up on this and identifying those patients than we are. We simply don't have a lot of training in that just yet, although we're doing our best to change that. So I'm going to finish by just talking about a new concept, a new condition that you may or may not have heard about. But we're doing work on this at Michigan, and I must say we're achieving some very surprising results, which I'll just give you a glimpse of in a minute. So recognize that in the brush border, the intestinal brush border, there are 2 main disaccharides. Lactase, which you're very familiar with, and conceptually I think you all know that lactase breaks down lactose to its constituent monosaccharides, glucose and galactose, which can then be absorbed by the small intestine. When you're deficient in lactase, you cannot break down the disaccharide and it can't be absorbed. So it gets to the colon where it's fermented, it becomes a FODMAP. It turns out that the other main brush border enzyme is sucrase-isomaltase. You probably remember this from medical school, but you probably don't remember very much else because we really don't talk about this as adult gastroenterologists. Now, the pediatric gastroenterologists are very familiar with sucrase-isomaltase deficiency, and in fact, very routinely, pediatric gastroenterologists will do small bowel mucosal biopsy for disaccharidase enzyme levels, including sucrase-isomaltase levels. So they're very familiar with SID, sucrase-isomaltase deficiency. Realize that breaks down into 2 broad categories. Congenital or genetic sucrase-isomaltase deficiency, which is genetically confirmed and mediated, or acquired sucrase-isomaltase deficiency. So, for example, just to give you some things to think about, patients with celiac disease can have acquired sucrase-isomaltase deficiency. Anything that wipes out the brush border will wipe out SID activity. Patients with Crohn's disease can also very commonly have sucrase-isomaltase deficiency. Yet this is a condition that very few of us, I bet, either think about or certainly almost none test for. So remember that sucrase-isomaltase is responsible for breaking down sucrose into glucose and fructose, which can then be absorbed in their monosaccharide forms by the human small intestine. And in the presence of sucrase-isomaltase deficiency, sucrose cannot be broken down into its monosaccharides, and it becomes a FODMAP. Okay, so just like in lactase deficiency, lactose becomes a FODMAP. In sucrase-isomaltase deficiency, sucrose and certain starches become FODMAPs. It also turns out in work published by Mauro D'Amato, and Lynn collaborated on this work as I did as well, he actually has described that mutations responsible for sucrase-isomaltase deficiency are enriched in patients with IBS-D. So IBS-D patients are more likely to harbor genetic mutations which confer sucrase-isomaltase deficiency. We've also shown, just recently in a letter that we published in Gut, what we did is we took blood samples that we collected during our randomized controlled trial evaluating the low-FODMAP diet versus usual dietary recommendations in IBS-D patients from the Midwest U.S. And what we found was that individuals who responded to the low-FODMAP diet were more likely not to have sucrase-isomaltase mutations than individuals that didn't respond to the low-FODMAP diet. So another way to say this, individuals that didn't respond to the low-FODMAP diet were enriched for SID mutations, which kind of makes sense. Now, here's the other implication of that. We're doing some additional work to follow up on this, is if this is true, you may want to think about testing for sucrase-isomaltase deficiency in patients that have food-related symptoms that don't get better with the low-FODMAP diet. It also may turn out that if this is prevalent enough that we may want to start thinking about testing for sucrase-isomaltase deficiency as we start to think about which diet strategies are most appropriate for our patients with IBS-D. We're currently doing a large prevalence study where we're doing disaccharide enzyme assays in patients with IBS-D. I can't share with you the final results yet, but I will give you a teaser, which is that we're finding that around 5 to 10% of IBS-D patients actually have decreased levels of sucrase-isomaltase enzyme in small bowel biopsies, which is was very surprising to us, actually. So to summarize, elimination diets may provide benefits to a subgroup of IBS patients. Low FODMAP is probably around 50 to 60%. The greatest weight of evidence supports the low FODMAP diet at the current time, but by no means is that the only diet that people are utilizing or for which there are studies in patients with IBS. Other elimination diets do require, however, more validation. I think that the other diets outside of low FODMAP are really more hypothesis generating at the current time. They really haven't been adequately proven to be efficacious in patients with IBS. Emerging data suggests that atypical food allergies may also be important. I didn't have time to talk through this, but there's some very interesting work using confocal laser endomicroscopy from Germany suggesting that there may be a subgroup of IBS-D patients who actually have an immunologic response to the ingestion of certain dietary proteins like gluten, like casein, and other milk-related proteins. So we can certainly talk about that in the Q&A. Emerging data suggests sucrase-isomaltase deficiency can also cause GI symptoms in a small percentage of IBS patients and may be enriched in patients with meal-related symptoms who do not respond to the low FODMAP diet. So with that, I'll close. We have our course for GI dietitians, as we do every year. In August this year, it's the only course in the United States that's exclusively developed for GI dietitians. In fact, Nancy Jaffe is going to be coming out and being one of our featured speakers this year. We decided to share the wealth with UCLA. And so if you're interested in getting a dietitian trained, this is a wonderful opportunity for them to come and mingle with the other people in this space and gain really intensive information and training about GI nutrition. Thank you very much for your attention.
I guess we didn't have cards, but you have a question?
Yeah, so the comment is about whether there are changes in food constituents in association with cooking, and specifically slow cooking. I don't know that I can answer your question about slow cooking specifically. I don't know the answer to that, but we're doing a lot of diet-related research, as Lynn alluded to, and we're finding all sorts of things that we didn't know that actually make doing diet research fairly complicated. One of them has to do with your comment, which is that carbohydrates, FODMAPs, depending upon the matrix that you deliver and the way and how long you cook them, behave differently in different circumstances. So for example, let me just give you an example. We just got data on this literally 2 weeks ago. The way a person reacts in terms of hydrogen breath testing, for example, in response to giving a FODMAP in a liquid form versus a solid form, an uncooked solid form versus a cooked solid form is completely different. So this is going to add an additional layer of complication onto sort of thinking about conducting and looking at results from this research. But it does kind of make sense if you think about it. If you give fructose in a liquid as opposed to in a solid matrix, of course the transit's going to be completely different. And so how that relates to symptom-based studies, I'm not sure about, but certainly for studies like looking at breath testing, for example, you're going to need to know details in regards to how the substrate was delivered and whether or not and how long and it was cooked, et cetera, because all those things probably end up mattering. And certainly for proteins, you'd expect that too as well.
Bill,
So very interesting question.
Bill, I want to ask you, just from a clinically practical point of view right now, if somebody is thinking about this sucrase-isomaltase deficiency in their patients, what exactly should they do? And if they see it, what are they going to do about it?
Yeah. So there are a couple different ways in which to make this diagnosis. The easiest one is a sucrose breath test. Now, the problem with a sucrose breath test is there are no studies really validating the performance characteristics of sucrose breath testing. The other problem is it's going to be confounded by bacterial overgrowth. So if you believe in the theory of bacterial overgrowth being more common amongst patients with IBS, it injects a huge layer of problems doing a sucrose breath test in patients with IBS-D to diagnose sucrase-isomaltase deficiency. In other words, there's no real way to distinguish between whether it's from SID or from bacterial overgrowth. The other way is to do intestinal biopsies for quantitative disaccharidase assay. Unfortunately, that's not widely available in the United States, although it's becoming more and more available. Realize that the pediatric gastroenterologists, again, have been doing this for a long time. And one bit of advice would be, if you have pediatric gastroenterologists in your area, ask them how they're testing for it. Because they're the ones locally with sort of boots on the ground kind of information that can help you to know how you want to order this if you do in fact want to order it in your clinical practice. We have a lab that we're working with in Florida that it's actually a national reference lab that does this testing, and there are a number of reference laboratories across the United States that one could order this from. Obviously, it does require a little bit of training. A good resource there is QOL. Actually has QOL Medical makes a enzyme supplement called Sucrate, and they're very familiar with the testing facilities around the United States and also about how to do the testing. So they would be a good person to think about. The last way would be blood testing for the mutations associated with SID. Those are widely available, but you'll miss acquired sucrase-isomaltase deficiency. So you'd identify individuals with the known genetic variants of SID, but you won't pick up the acquired SID. And there's a bit of debate about this. My own personal bias is, at the end of the day, I think we're going to find that a lot, at least as much, if not more of it, is acquired compared to congenital.
Kirsten had a question.
Yeah,
Yeah.
Bill, I had a question just in terms of the practicality now. We may know that there will be these atypical food allergies and data may be emerging, but what do we do now with those patients who have questions about food allergies and how much of a role they may play in their symptoms?
Yeah, it's a tough question because, on the one hand, I really do believe that there are these patients out there. On the other hand, I don't believe that the currently available testing has been validated in a way that makes me confident to recommend it. That said, I'll just tell you that there are studies going on right now, for example, for IgG-based food sensitivity testing. Whether that'll shake out or not, we'll see. But we're doing and along with Harvard are actually doing a very large multi-center study, which we're about 3/4 of the way through. So we're hoping that by the end of this year, we'll actually have the first U.S. data, large, methodologically rigorous, with an attached intervention that we'll be able to share with everybody. There's also leukocyte activation testing, as you're aware of, that showed potential benefits in a study from Yale. So there is a small preliminary study with leukocyte activation testing. But beyond that, really, there's a lot of stuff going on in the marketplace right now with not a whole lot of data. Now, that doesn't mean it doesn't work. Like mediated release testing would be another great example of something that people are using a lot in clinical practice, but for which there's absolutely no randomized controlled data. It doesn't mean it doesn't work, but what you'd have to say in fairness is we really don't know whether it works or not.
Okay, thanks.
Thanks, Bill. I think what you can do is put your questions on the cards, and you can give it to me at the lunch or near when we get near the Q&A. Okay, so I'm going to go to our next case. This is an 18-year-old college student accompanied by parents for upper abdominal pain, bloating, and constipation for many years, but worsened 5 years ago. So 5 years ago, the constipation got worse, required the patient to take an occasional PEG or laxatives just to have a bowel movement. Had a diagnostic evaluation, so this is when they were younger, so probably like 13 or so. Had at a children's hospital, diagnosed with median arcuate ligament syndrome, underwent a robotic release. Then intraoperatively, they know that the pylorus was unusually prominent. And after surgery, the pain partially improved, but the patient continued to have some bloating. So because the pylorus was prominent, they decided to do Botox injections at the pylorus. And the patient said that there's some transient relief in both pain and bloating, but still had these symptoms. Pain and bloating increased after the patient started college. She had extensive workup, including an EGD, MRE, MRI angiogram, gastric emptying scan, lactulose hydrogen breath tests, which were all normal. Diet's very limited, was seen by a psychiatrist who didn't believe that the symptoms were due to an underlying eating disorder. Currently has abdominal pain after 10 to 15 minutes of eating. Pain is present first thing in the morning when she wakes up without any food intake, but gets worse after eating. No nausea or vomiting. Bowel movements are usually normal, one bowel movement daily with a Bristol stool form scale of type 3, which is just it's still normal, but harder. Although she reports having occasional constipation associated with straining. She's tried multiple medications, including amitriptyline, prednisone, ondansetron, Librium, erythromycin, cyproheptadine, prucalopride, none of which have helped her symptoms. So I don't have that much time, I'm going to keep going. Her symptoms I thought were compatible with functional dyspepsia, postprandial distress syndrome, and chronic idiopathic constipation. I recommended referrals to the GI dietitian, GI integrative health practitioner, which is Suzanne, and our GI health psychologist. Because I thought that she had more of this visceral hypersensitivity, I prescribed duloxetine, which is an SNRI, and told her to continue magnesium for her constipation. She was exercising daily, but I thought maybe, and it was more cardiovascular, and I thought maybe she can incorporate different types of exercise, perhaps yoga, which has been shown to have some benefit in functional GI disorders. And then Christina Gentile saw our patient who did an assessment and management, and fortunately she knows how to do this assessment for avoidant restrictive food intake disorder, and she also did a fear of food frequency questionnaire, a fear of food questionnaire as well. But for the first one, the ARFID disorder screen, there's a score of 33 out of 45, and higher scores are suggestive of the patient having more of this avoidant restrictive eating behavior. And the patient had a subscale of fear and appetite on the subscales. And the FFQ score was 70 out of 90, and the higher scores are suggestive of more severe distress associated with fear of GI symptoms after eating particular foods, and fear avoidance of foods themselves, social impairment, and loss of pleasure in eating. And it was recommended to do gut-directed hypnotherapy for symptoms which has helped her regulate her emotional response to symptoms and stressors. So we're going to have Janelle talk about this, but before we do that and get the GI dietitian perspective, so I want to ask Christina, from your standpoint, and you do this assessment, what is your approach when you see someone? You probably don't do it in everybody, and when you see this, what do you think, what are your thoughts about managing this?
In terms of management, well, first I do the assessment with the measures that Dr. Chang has listed. I'm also looking at, is there any premorbid clinical eating disorder or subclinical disordered eating, as Janelle will be talking about as well as their relationship with food. And in terms of management, ideally we want to do cognitive behavioral therapy, AR, for avoidant restrictive food intake. But with this patient, she was not open to that approach, so we had to find her access point, which was gut-directed hypnosis. But ideally, we want to use the cognitive behavioral therapies, similar to the patient that I talked about yesterday who had this fear of choking when swallowing.
Yeah, I just find that, with the elimination diets, and there's a lot of diets now where, and a lot of people are just doing like for 30 days, they'll do one thing of fasting and they'll go to another diet for 30. So I just feeling like it's getting more common. And I don't know if it's particularly younger people too that are interested in different diets, but that as we're starting to do more elimination, I find particularly in the severe patients that you're seeing people that are eliminating foods, even if there's an inconsistent response to their symptoms. And then they come and they're on like a few foods and they eat the same thing all the time. And now this is getting to be the problem. So you see that there's some benefit in doing eliminating certain foods, but if you go overkill, then you get a little bit in trouble, right? So I know Bill has done a lot of work on this. So Janelle Smith, who's our GI dietitian, is going to talk about avoidant restrictive food intake disorder.
Thank you so much. So as Dr. Chey has just presented with a great overview of diet for functional GI disorders, particularly IBS, I also quote him in this slide. Diet therapy for GI disorders can be very effective. It can be essential, such as in celiac disease or EOE that's non-responsive to medication. It may be the only treatment. It can be very effective, such as in irritable bowel syndrome, with a similar response to medical therapies. And I would say it's egosyntonic. Patients like to have a sense of control over their symptoms and participation in care. So when a physician recommends an elimination diet, it actually aligns the patient's expectations with the physician and can create more buy-in. But there are times when diet therapy does more harm than good. When it leads to inadequate protein or energy intake, unintentional weight loss, nutrient deficiency, heightened anxiety and attention around food, when someone has limited resources to prepare specialty food and they end up not being able to eat a specific diet, there becomes fear of hidden ingredients, contamination, and social isolation. So how prevalent is this problem? Show of hands, do you see this in your practice? Yeah, I think we've seen it for a long time, but we haven't had the words to say, is this an eating disorder or not? In 2013, Quick and all kind of went over the existing evidence for disordered eating and diet-related chronic health conditions. It's been known that disordered eating is higher in diabetes mellitus type 1, celiac disease, cystic fibrosis, inflammatory bowel disease, and IBS. And then this meta-analysis by Satherley showed about 23% of patients with GI disease in particular scored positively for disordered eating using these tools. And significantly higher than healthy controls and associated with higher overall anxiety scores and higher incidence of GI symptoms. So I want to take a moment to differentiate between disordered eating, as Dr. Gentile mentioned, a subclinical kind of term, and then an eating disorder, and then I'm going to introduce the feeding disorder of ARFID. So disordered eating includes those abnormal behaviors that maybe are not culturally sanctioned, albeit in LA there are a lot of abnormal eating behaviors that are culturally sanctioned. Things like restraint eating, oh, I don't eat this, I only eat this one time a year, skipping of meals, low variety of food intake, periods of loss of control eating, which could turn into binge eating, emotional overeating or emotional undereating, maybe accompanied by attempts at changing weight and body shape, or accompanied by compensatory behaviors such as self-induced vomiting, laxative use, or overexercise. And that's a real common one prescribed by personal trainers. If you eat that pizza, just burn it off the next day. So at some point, these disordered eating behaviors become clinically significant. And the significance is defined by the DSM and should be kind of undertaken with a psychologist. That has significant psychosocial impact on mood, quality of life, also physical consequences that may endanger health. It's always accompanied by an undue importance placed on body weight or image. So that's the key feature of eating disorders, is that patients, whether they're in a smaller body or a larger body, they care very much about their weight and their body appearance, and they may have dysmorphia in terms of they think that, regardless of what others think, that they still need to be losing weight. So the frequency and severity of disordered eating behaviors, fall within these diagnostic guidelines for anorexia nervosa, bulimia nervosa, binge eating disorder, or another specified eating disorder. And we know from eating disorder literature that approximately 20% of individuals who have dieting behaviors and disordered eating, subclinical disordered eating, will actually convert to a clinical eating disorder at some point in their life. But what about these feeding disorders? Feeding disorders have significant psychosocial and physical consequences and may include the exact same disordered eating behaviors, skipping meals, low variety, taking small bites, etc. But there's not body dysmorphia. Patients are aware that they're underweight or they're aware of their size, and they don't have a fear of fatness. At least they don't express it on presentation. However, I have had many a patient switch from feeding disorder to eating disorder once they get to a healthy weight, and they say, actually, I don't want to gain more weight. The feeding disorders include rumination disorder that we discussed yesterday. The rumination can co-occur with bulimia, anorexia, etc. Pica, the eating of non-nutritive substances, and ARFID. So avoidant restrictive food intake disorder. This diagnosis was coined in 2013 in the DSM-5, and 7 years later, there are still no validated treatment methods. So something to know is that this is a very emergent area of inquiry. So ARFID is characterized by food avoidance or restriction that's motivated by either the sensory characteristics of food or avoidance of trying new foods, lack of interest overall in eating food, kind of a low appetite, or fear of aversive consequences of eating. And patients may have one or more of these subtypes. It must lead to maladaptive consequences, including, but not limited, it doesn't have to include all of them, weight loss, failure to thrive, nutritional deficiency, dependence on oral nutrition supplements or tube feeding. I personally would argue that an inappropriate dependence on TPN would fall under this, and significant psychosocial impairment. So in ARFID, the food restriction is not driven by concerns about body shape or weight. There typically is not a body image disturbance. Patients will say they're concerned about their weight changes. It can't be attributable to a medical condition. So if a person is diagnosed with dysphagia and they're eating less and losing weight because of the dysphagia, that is not necessarily ARFID. But if the disturbance in eating exceeds what's typical for that medical condition, it may now be classified as ARFID. And I think we have a lot of work to do in the GI community to decide what is typical food fear in irritable bowel syndrome and other GI disorders. The screening tools mentioned are not yet validated in a general population, let alone a GI population. Their diagnostic tools are validated, and treatment is not yet evidence-based. So we have a lot to learn about ARFID. This is one of the emerging, thank you, one of the emerging screening tools, the 9-item ARFID screen. And this is really easy to use in clinic. This is the one that Dr. Gentile had used. It's on a 5-point Likert scale, ranging from strongly disagree to strongly agree. And we see the 3 different factors. So some individuals will only score high in the picky eating factor or the low appetite factor. And as we see, a lot of our GI patients score high in factor 3, which is fear of aversive consequences. In Herrer et al. Presented a poster session in 2018, along with Dr. Chey's group, 223 patients who were referred from a gastroenterologist to a GI psychologist were evaluated retrospectively for ARFID, majority female. They found that 12.5% almost met the criteria for ARFID. That the vast majority of them had already tried a formal diet prior to meeting with a dietitian, so they had self-restricted their food intake, so to speak, or they had been prescribed by a gastroenterologist despite having low body weight or active weight loss. Concern for ARFID was not documented in any of these patients' notes, and not a majority, only 28.6% had a pre-existing psychiatric diagnosis. In Zia et al. Presented at the 2019 AGA annual meeting, they looked at ARFID in patients with functional GI disorders, similar population. Findings were 28% with eating disorder pathology or disordered eating behaviors, as we might say, and 21% met the full criteria for ARFID, associated with higher depression and lower BMI. One final study in our GI, functional GI patients similarly found 6% who met full criteria for ARFID and 17.3% with clinically significant behaviors. So far in 3 studies, we have a range of 6 to 10%, 6 to 10% prevalence of this problem in our GI patients. So as I said, there are not evidence-based treatments at the time, but many are under review and having promising results. Mirtazapine and olanzapine and D-cycloserine have been proposed to be used as treatments in ARFID in order to increase appetite and decrease anxiety. It may be necessary to do an inpatient refeeding program, especially in these patients who are significantly malnourished or underweight. If there's a risk of refeeding syndrome, if there's bradycardia, hypotension, or significant electrolyte abnormalities, that would be an indication for refeeding inpatient. Cognitive behavioral therapy for ARFID, CBT-AR, is under development for validation, and that can be done in an outpatient setting over a course of, at least 20 visits, so it's a longer-term treatment. Exposure and response prevention, it can be part of that or used separately, and family-based treatment kind of mimics the treatment setting in an inpatient setting at home with the family. So far, expert consensus agrees that the first goal should be to resolve low body weight first. Exposure therapy, even psychoactive medications, and cognitive behavioral therapy are not as effective in underweight individuals. We know this already from treating anorexia nervosa. So my primary goal as a dietitian usually is to use calorically dense foods that are already acceptable to that person in order to increase their body weight. We can gradually increase the volume at meals or increase the frequency of meals and snacks. And if a patient really has ARFID and no body image disturbance, they typically take to this really well and are happy to eat more in order to gain weight. Experts agree that the treatment should include transitioning off of nutrition support or oral nutrition supplements, improving food variety so that all major food groups are present multiple days of week, and address the psychosocial distress that's involved with social eating. So recommendations for us as providers. We all can be screening. Mental health providers, dietitians, physicians, especially gastroenterologists and allergists, immunologists, speech-language pathologists, occupational therapists, caregivers, and loved ones. I frequently, if there's a loved one in the room, will ask if they have any concerns about their loved one's eating behaviors, which may be a more accurate representation. Diagnosis, however, is best made by a mental health professional using a validated interview. As physicians, this ARFID work group in Eddy et al. 2019 recommends that we need to rule out underlying GI pathology if food difficulties don't improve with standard care, if there's localized or nocturnal abdominal pain, recurrent diarrhea, vomiting, blood and stool, dysphagia, systemic symptoms such as fever, rash, oral ulcers, joint pain, or a family history of autoimmune disease. Red flags that you may see in patients and consider disordered eating, if the disordered eating is clinically significant. If there's progressive restriction within an already restricted diet, as Dr. Chang was mentioning, the list of foods that won't be eaten is much longer than the list of foods that will be eaten, and it doesn't necessarily comply with an evidence-based diet like low-FODMAP diet. Refusal to introduce foods, or a lot of times patients will say, I've tried, but I can't, or they have too much anxiety to reintroduce foods. Discordance of the clinical presentation or history. I have a patient recently who just accidentally was a BMI of 16 and doesn't understand how that happened. That shows a real lack of awareness or not giving a lot of information. Lack of patient concern over the severely restricted diet or the weight loss and evidence of body dysmorphia actually fall under the eating disorder category and would not be typical of ARFID, although there is a lot of overlap. And any difficulty in regaining weight, in my opinion, is cause for attention. Thank you.
Thank you. Yeah, we have a question here on the panel.
So I have a question for Janelle or anyone on this panel. My patients who I'm referring to you for consideration of an elimination diet, it's very easy to convince them to go see you. But my patients who I see in clinic who are only eating 4 things or 5 things and have disordered eating behaviors are much more reluctant to accept a referral. So my question is how can we help, or what should we say to those patients to get them to consider adding more food?
First of all, I would like to say in disordered eating, the dietitian is the most hated provider because they try to regain control over the patient's food. And having control over food, whether it's body image related or not, is what threatens their safety behaviors or the way that they cope with their anxiety. So to me, that's a good clue. If someone is resistant to seeing a dietitian, I would probably recommend trying to enter through the psych door. And what do you think, Christina?
Like Janelle, I become easily hated too, especially when I'm reinforcing her or Nancy's diet, their recommendations. But going through the psych route, then we could offer psychoeducation on some of the cognitive variables that are at play, help promote some motivation, address ambivalence, and even if it's resistance, helping roll with that resistance, helping the patient develop some discrepancy between maybe their health values and how they want to do more of what brings them joy and what they value, but because of what's going on, there's a block here. So sometimes that can help potentiate a little bit more motivation and help set the stage, or at least plant the seed for the possibility then of, better work with Janelle and follow up with you.
There's sometimes, but you have to get them in the door, I guess, which is what Lynn Connolly is saying. So, sometimes I'll try to approach it from just a healthy nutrition standpoint. You just want to have someone evaluate just we want you to be healthy, and they're never going to say, no, I don't want to be. And just from a nutritional standpoint, to help work with me and to help you, all of us work together. So sometimes I take that kind of approach, or say something that, not to make them feel it's going to be a little more gradual, because I think it's exactly what Janelle said, it's having control. And if they feel like someone's going to take the control, or it's going to go too fast for them, and they're not ready, they're going to resist. I don't know, Bill, what do you do? Or Kirsten?
Well, I have a comment, which is a bit of a word of caution on this. So I'm super excited about the fact that people are recognizing that ARFID exists, that it's a significant problem in GI practices, but a couple words of caution. The first one is just remember that we're doing the same thing you guys are doing, but be careful about using the 9-item screener because it's not validated for GI disease. This is a really important point because to me, the biggest struggle in clinical practice is going to be about trying to distinguish between what is appropriate restriction based upon the underlying GI pathology and where is the line that gets drawn to where it becomes pathological. And although that seems like it's really simple to differentiate, it's actually not. There are a lot of patients that to some degree are appropriately restricting foods related to problems that they have. And again, depending upon where your threshold is, you may interpret that to be inappropriate. And we really need some science to help guide us as to where that line exists. And we don't have that right now. And right now, all of the data that we're going on, with the exception of the few abstracts that were presented in the last talk, are really general descriptions of ARFID, not in GI patients. And I think you just have to remember that ARFID in GI patients presents its own unique set of challenges that we're going to have to sort through as we learn about where this condition actually resides and how we treat it.
I just want to add to that because I think that's a really key point, and I would go even a little bit further. So sometimes when we become very frustrated as a gastroenterologist with a story that somebody comes to us that just seems impossible that they could only eat these foods, right? And then we get stuck in this place where we don't really know what to do, and so it's very easy to come up with well, they must have an eating disorder. This is not my problem. And so I think we have to be super cautious about that, and it goes to exactly what you're saying. If we approach the patient with, you know what, I think you might have an eating disorder, that's not going to get them to see the dietitian. We really have to do exactly what Lynn suggested, really explicitly. What is your goal, and how can I help you achieve your goal? And if your goal is, I feel too tired, I'm too skinny, I want to be more energetic and gain weight, then I think, what's been helpful for me is sort of that permission to say, okay, well, maybe we don't have to broaden out the diet right away, which is my initial instinct. It's saying, okay, well, let's go with your safe foods, and let's try to move you along. And you know what? It's not my expertise to help you decide what the next food is to reintroduce, but I work with these experts who can help you figure out what's the next thing we should add in because they know what symptom it may cause. And that's my way to sort of bring you on as an ally rather than as a treater of their behaviors.
Yeah, I couldn't agree more. And, I think all of this really speaks to the way that the paradigm is really shifting to really a multidisciplinary model. We literally just last week sent in a review article on integrative care for IBS. It was myself, Peter Gibson, Kevin Whalen, and Lori Kiefer wrote this article. And the last paragraph, which I wrote, so I know it very well, the whole thing is about how really the modern referral practice should really must integrate elements of GI nutrition, behavioral medicine, and traditional Western medical therapy. And I know that's easier said than done. It's easy for me to say that in the ivory tower. I get that. It's not going to happen overnight, but we should all be working towards that end, is developing these collaborative care models that allow patients and you to have choices. Because the other thing is, just remember, this is not, the first and foremost thing is to do the right thing for the patients, but I can tell you from experience, I'm sure Lynn can reiterate this, once you have this model, you'll wonder how you did it without the model. Having these different elements tremendously enhances your ability to be able to adequately address the patient's problems.
Yeah, I was just thinking, just looking at the panel, and also you will have obviously the sense that these sessions are about an integrative care model and care approach, because that's really, I think, what we're moving to. Luckily at UCLA we have that option, but I think nationwide they're recognizing that providers and patients need greater access to the integrative team, so they're doing more internet-based telemedicine type approaches so that patients can access these providers. Okay, we're going to move on to another case, and this case I'm going to bring back at the end after Lynn, Connolly, and I talk, but just to set the stage. So this is a 52-year-old woman who was referred to GI for a history of intermittent periumbilical abdominal pain since her 20s, but it's become constant for the past at least 10 years. Occasionally, she has infrequent hard stools, but manages this with over-the-counter laxatives. Constipation is associated with discomfort and bloating, but it's not with daily abdominal pain. So there's not an association with the constipation with the pain. Has taken opioids rarely, but tries to avoid them and knows what it can do to her system. Tried antispasmodics and a low-dose tricyclic agent for a couple of weeks, but this caused dizziness, dry mouth, and constipation. She had diagnostic lab and imaging studies, which were negative. Is including a CT scan. Colonoscopy was normal except for 2 tubular adenomas, small internal hemorrhoids. She had an anorectal manometry that showed a normal squeeze pressure and a good relaxation during bear down, and she was able to expel the rectal balloon. So basically didn't have dysynergic defecation. She's unable to work, and she's seeking disability. She has a history of childhood verbal and sexual abuse and adulthood stressors. So this is probably a patient that I think a lot of us on the panel have seen. I mean, not this particular patient, but it's a patient like her. And so we're kind of starting, so I want to move to how do you work up and how do you manage chronic abdominal pain. So Lynn Connolly is going to give this talk on diagnostic assessment of chronic abdominal pain.
Thank you. So I'm going to try in the next 15 minutes to run through how to approach these patients with chronic abdominal pain. What is the appropriate workup? How to differentiate between the functional bowel disorders that can present with chronic abdominal pain, and when to stop ordering tests and reassure your patient. The chief complaint of a chronic abdominal pain is challenging for a number of reasons. One is that the differential diagnosis list is very, very long, well beyond what's on this slide. And also because the list includes things that are not GI in origin. So for example, there can be significant overlap in the visceral innervation of the uterus and cervix and the rectosigmoid area, which can make it challenging sometimes in the office to differentiate between lower abdominal and pelvic pain that is GI or gynecologic in origin. So in your patients who are female, who are presenting with chronic lower abdominal pain and pelvic pain, you should be considering and thinking of things like endometriosis, chronic pelvic pain, interstitial cystitis, and myofascial pain syndrome. Another common conclusion that we'll see is, the pain must be from adhesions because I've had surgery. And yes, there is some debate still that maybe adhesions can cause pain, but certainly there's no robust evidence at this point that adhesions are causing pain beyond that of acute and subacute bowel obstruction. So when you first see these patients in the clinic, my guess is the first question you're asking is, where exactly is your pain? And if the patient says it's localized, we all take a big sigh of relief, that gives us a starting point. And on physical exam, you'll be looking for a Carnett sign. As a reminder, a positive Carnett sign is when the patient's local pain stays the same or gets worse when you have them tense their abdominal wall muscles in a partial sit-up. A positive Carnett sign, where it does stay the same or get worse, has a 97% diagnostic accuracy for abdominal wall pain. And the most common and frequently missed chronic abdominal wall pain is anterior cutaneous nerve entrapment syndrome. These are your patients that are coming in with chronic abdominal pain on the lateral edge of their rectus abdominis. If the Carnett sign is negative and their pain actually gets better when they tense their abdominal muscles, then that implies an intra-abdominal or visceral cause of their abdominal pain. So last year, Mark Pimentel and a colleague published what I thought was a very good article on abdominal pain that I encourage you all to read. And this chart serves as a reminder that there are a number of systemic conditions that can present with chronic abdominal pain that really require a high index of suspicion in order to diagnose. So for example, in an appropriate ethnic group where you have a patient with episodic abdominal pain and fever, you may want to consider familial Mediterranean fever and refer to Terry Getzig at Westwood. For a patient, an older patient, a female patient who is coming in with a history of chronic of peripheral vascular disease, coronary artery disease, you may want to order a CT angio to look for chronic mesenteric ischemia. There are a number of other very rare conditions on here that, again, should just be somewhere in the back of your mind so that in the appropriate context, you remember to do the evaluation for them. But the vast majority of the patients that you're going to be seeing that are coming in with chronic abdominal pain that don't have a diagnosis by now will likely be functional in origin. The top two being IBS and functional dyspepsia, of course. Centrally mediated abdominal pain syndrome, which is a mouthful, so I'll refer to as CAPS, is not as prevalent at a prevalence rate of about 0.5 to 2%. And then there's a more newly described condition called narcotic bowel syndrome, which is when a patient presents with paradoxical worsening of their abdominal pain despite escalating doses of opioids. The pain is felt to be related in part to opioid-induced hyperalgesia, and in order to have the patient's pain improve, you have to dramatically reduce or stop the opioids altogether. So at this point in the office visit, if you think that your patient's chronic abdominal pain is a functional bowel disorder, what do? Do you just diagnose everybody with IBS and move on to treatment, or do we continue to do a workup? The first question is, of course, is in your history and exam, did you find an alarm feature? And if so, stop and do the appropriate diagnostic workup for that feature. I think everyone in this room is familiar with what symptoms are red flags, but I will just remind you that not every patient with a structural cause of their abdominal pain is going to have one of these red flags. If your patient does not have an alarm feature, then the next question is the chronic abdominal pain related or associated with eating, bowel movements, or menses? And if so, you may want to consider functional bowel disorders such as IBS or functional dyspepsia. And in the right clinical context, maybe reconsider a gynecologic disorder or a structural GI disorder. We've gone through IBS before, but just as a reminder, these patients have to have abdominal pain once a week, and they do have to have some sort of relationship to defecation. There are two subtypes of functional dyspepsia. Epigastric pain syndrome is the subtype that presents with weekly epigastric pain or burning that is severe enough that impacts these patients' usual life activities and or prevents them from eating a normal size meal. If your patient has continuous or nearly continuous abdominal pain, it is not or rarely associated with menses or eating or defecation. There are no alarm symptoms, and you do not think that the patient's pain is feigned or represents drug-seeking behavior, then you will want to consider centrally mediated abdominal pain syndrome. So this, of course, was just recently changed, so most of us still know this as functional abdominal pain. And it's characterized by continuous or nearly continuous, we're talking about almost daily abdominal pain that is very severe. In certain patients, especially after surgery, they may describe it as burning. There's only a rare or poor association with physiologic events such as diet or having bowel movements. And these are the patients where the abdominal pain is so severe that it has created a significant impact in their quality of life. These are the people who are asking for disability or having problems at work with their social life, their personal life. It's significantly affecting their daily function. So at this point, if you have diagnosed, if the patient's met Rome 4 criteria for one of these functional bowel disorders as the cause of their chronic abdominal pain, what additional workup should you do? Well, everyone should get a CBC and, of course, age-appropriate colorectal cancer screening, especially this month. If your patient has functional dyspepsia, or you think they do, you should get an upper endoscopy before confirming that diagnosis. If your patient has diarrhea-predominant IBS, you'll be considering making sure that you've ruled out celiac disease, giardia, and getting a fecal calprotectin, which is a more specific inflammatory marker for bowel inflammation. With patients with CAPS, you may also want to get an inflammatory marker, a fecal calprotectin. And if any of your patients have an elevated fecal calprotectin, consider colonoscopy and workup for inflammatory bowel disorder. So I often get asked by doctors or fellows, so what is IBS and CAPS basically the same thing? It's just that IBS also has diarrhea or constipation. And the answer is no, although CAPS may represent the far end of the severity of IBS, where the patient's pain is much more severe, it's more prolonged, it's more diffuse. But another thing that differentiates them is what can be the driving variables. So with centrally mediated abdominal pain syndrome, the psychosocial variables play a huge role. These are things like life stress, anxiety or depression, history of abuse or poor social support. And you may have less of an impact of the low FODMAP, less of an impact of a diet with these patients compared to patients with IBS where, as we've heard, diet may play a much bigger role. A question that I get from patients is, well, I've had this abdominal pain for 10 years, and I was only recently given Norco 3 years ago, or my life stress that caused me all this anxiety was only 4 years ago. So you can't tell me that my abdominal pain is from one of those things. And my response is a reminder that whatever caused your abdominal pain when it started 5 or 10 years ago might not be the same thing that's driving the pain now. So it may have been that the pain started with traveler's diarrhea or surgery, but over time, that peripherally based pain changes to a pattern of central disinhibition, where the pain becomes constant and not responsive to the prior treatments that address the peripheral pain. Now, while there is no consistent psychologic profile in patients with CAPS, there often is overlapping anxiety, depression, somatization, and pain catastrophizing disorders. And while we, of course, are not psychologists, we do need to investigate that in our patients because it really impacts their poor quality of life. So this slide, I think, is important and can also apply for the other functional bowel disorders, which is that if you've gotten this far, your patient meets Rome 4 criteria for one of these diagnoses. There is no alarm symptoms. You've done the appropriate workup. Then that's it. You've made the diagnosis. You don't have to just keep on testing. Diagnostic failures are very rare, and patients who have functional bowel disorders do not actually say that they have improved health-related quality of life with each additional test that comes back negative. Now that's easy, of course, for us to say, but the elephant in the clinic room is that the patient and the doctor, of course, is thinking in the back of their mind, well, did I miss something? Am I sure? What if I miss cancer? And the irony is raise your hand if you've ever had a patient complain that their doctor missed IBS. It's just not that common. We're very, very concerned, doctors and patients, about missing an organic disease. And some of that has to do with that we have this societal bias against brain-gut disorders. We want to be able to see what's wrong. We want to be able to look at a test, a lab result, a CT scan, and be able to physically see with our own eyes. And while we're working and making progress on biomarkers, at the moment, we don't have them. So what happens with patients when they get this diagnosis from us of a functional bowel disorder, many times they interpret that we, their doctors, just think it's all in their head. So what do? Well, oftentimes we start ordering tests. We get another CT scan, we get a colonoscopy, maybe even send them to surgery, have them come back. And maybe we do that because we think that our patients will feel better if we, quote, rule everything out. But the data actually suggests the opposite, that the more CT scans and lab tests and imaging and procedures that we do, that doesn't actually change our diagnosis, reassure the patients, or improve their health-related quality of life. So I'll end with, if you've made a diagnosis from a patient who comes in with chronic abdominal pain of a functional bowel disorder, be confident in that and be able to explain it to your patients. And to do that, we need to stop and listen, don't interrupt, sit across from our patients, don't stand over them. And I think it's very important to understand or try to understand our patients' agenda and what their expectations are for the visit and also for the diagnosis and the treatment so that we can try to align the expectations. If this is a functional bowel diagnosis, we should be able to make a pretty prompt diagnosis. And we need to reassure our patients that we have confidence in that. And to do that, we need to avoid repeating CT scan after CT scan if there's been no significant interval change, or ordering unnecessary invasive procedures or testing. And so I just encourage everyone to spend that time instead talking to your patients and trying to explain to them what's going on so that they can actually understand what's happening in their body and why they feel the way they do. Thank you.
So one question from the audience that has more relevance to your talk is, how do you address patients who tell you their previous doctor diagnosed them with leaky gut?
So this actually has to do with understanding their agenda and getting their expectations. So I remember when I was a fellow, if someone said leaky gut, the attending would basically say, that's absolutely impossible, you'd be in the ICU. And I do say that sometimes. But I think that instead I try to bridge the gap between the natural path or the alternative medicine doctor that your patient may be seeing and what we're trying to do in our clinic and our visit. So what I may say is that they may refer to that as leaky gut. I think what I would interpret leaky gut to mean is XYZ. And we still refer, many patients get L-glutamine. So I really try not to say you don't have leaky gut or you don't have SIBO if you don't think they have SIBO. I try instead to just kind of bridge the gap and come up with diagnoses that we use or symptoms that we use that may explain the same problem.
Yeah, I think that's a really good point, is to make sure that the patient's symptoms are due to the diagnosis that they perceive they have. I mean, leaky gut is the lay term for increased intestinal permeability or a disruption in the mucosal barrier function, which is being studied. It's not a clinical test right now, really. It's really used more for research. And there is some link of that pathologic finding in research studies with abdominal pain, but we definitely need more data. I don't know if you guys respond differently when the patient asks that.
Yeah, I have that happen a lot in clinic. And so I do talk about variations in intestinal permeability, and I let them know that there are these variations, and we know they can run in families. We know that taking regular NSAIDs can increase intestinal permeability, but that right now we don't tend to test for it, and we don't tend to think of it as the only factor that may be causing their symptoms. That might be a bystander. And so I don't disregard it, and I let them know that I think one of the key things that we can do as experts in the room is to acknowledge that we know what they're talking about and we've got a handle on it, instead of disregarding it completely. Because when they understand that we've actually heard of this, we've read about it, we know the biological significance of it, we can maybe reassure them that that shouldn't be our primary driver for the visit today, and that we think that there may be other things that we could do that could be helpful.
Sometimes I try to refocus the conversation on what got them there. So for example, I had a patient in clinic whose real problem was that she wasn't able to leave the house because she kept having bowel movements. But she was so focused on this new diagnosis that she had got of candida that she was completely unable to focus on anything but that. So while I didn't want to disregard that completely, the way I approached that was I tried to say, well, let's get back to what made you go see that physician, that naturopath, to begin with? It wasn't because you thought you had candida. It was because of X, Y, Z. So why don't we maybe refocus our visit on that?
I think that's an excellent point, is to get back, and I was thinking about it when Kirsten was talking, and it's a term that Doug Drossman uses a lot with communication with patients. It's called here and now, is where you try to get an assessment of what's the patient here and now, what are they thinking, what are their concerns, when you feel like you're not completely connecting with what is it that they really want. But I think that that's really a good approach.
Thank you.
Okay, so we have, I'm going to give the last lecture before lunchtime. So I'm going to talk about pharmacologic treatment of chronic abdominal pain. So the objectives are to review the efficacy of pharmacologic therapeutic approaches in IBS, specifically respect to abdominal pain relief, and I'm going to review the neuromodulators in painful functional GI disorders. Now, this is about chronic abdominal pain, but in general, if someone really has CAPS, they really need more centrally acting therapies. A peripherally acting agent or peripherally acting therapy is not going to be as effective. But most of the data that we have is in IBS, so I'm going to focus more on the IBS data, but the data specifically on reducing or relieving abdominal pain. But we have a lot of chronic or recurrent painful functional GI disorders that we could think about using some of the treatments that, even though they've been studied more in IBS, because that's just a disorder that's studied more, but we can think about using them in these other chronic painful GI disorders like functional chest pain, functional heartburn, functional dyspepsia, epigastric pain syndrome, CVS, biliary pain, CAPS, narcotic bowel syndrome, and functional anorectal pain. Okay, so I just wanted to show this slide first, and even though this is not a pharmacologic agent, but a lot of people do use probiotics, and there was a meta-analysis that specifically assessed if probiotics have a significant effect on pain. Because we know that there's some data, even though that's not always high-quality data, that can help overall symptoms or even bloating or gas. But in this meta-analysis, it showed that probiotics specifically just for pain was not effective. This is not to go over in any detail, but you have the slides, and I wanted to make sure that you had this data, but these are two leading GI societies, the AGA and ACG, and they have assessed and have published guidelines on pharmacotherapy for IBS. So usually the treatment for IBS is bowel habit specific. So I listed the IBS-D, that's diarrhea, IBS with constipation, and just IBS in general of the different agents. What's the recommendation? In black is AGA, in red it's ACG, and what's the quality of evidence? There's some agreement, but there's also some disagreement. And then the last column is, did it improve abdominal pain? If I said yes, that means it was statistically significant, but if there's an asterisk, it means that there was some imprecision because it's thought that to really be more definitive, the therapeutic gain between placebo and drug is at least 10%. And if the confidence interval was not over 10%, there's an asterisk. So it may not be as strong, but there was a significant benefit. So you see that PEG laxatives did not meet the criteria, and either did oxazolone, but I'm going to go over that in a minute. And SSRIs, there's some just, contradiction or conflict between what the AGA and the ACG feel, but in general, it's more weak data to suggest that it helps abdominal pain, and the AGA did not feel that it helped abdominal pain. Okay, so I'm going to talk about IBS with constipation, the data. So this is a figure I've used a lot, but it's just to the take-home point is over-the-counter laxatives, or laxatives in general, will help bowel habits, but they do not specifically help abdominal pain. Now, in patients with chronic idiopathic constipation, where they have some discomfort but not predominant pain, their discomfort can get better with these laxatives, or in those patients that have really more chronic idiopathic constipation, but they get pain when they haven't had a bowel movement for many days. If you start cleaning them out, their pain will get better. But just in standard IBS, which is still having predominant pain, even if you are having normal bowel movements, a PEG laxative is not going to necessarily get rid of the abdominal pain. So that's the point. So these are the mechanisms of secretagogues. And, God, it looks so small from there. But anyways, you can see this where the linaclotide and plecanatide, they work on the epithelial lining, and they are guanylate cyclase C agonists, and they increase a cyclic GMP, which causes the CFTR, primary chloride channel, to secrete chloride, and sodium and water will follow. We have tenapanor, which is FDA approved, and I'll show you data on that, but it is not available right now, but it is a sodium hydrogen exchange inhibitor, so it blocks reabsorption. And then lubiprostone works on the CLC2 chloride channel. So that is a secondary chloride channel. It works similarly to the other secretagogues of linaclotide and plecanatide, but works primarily on a different chloride channel. So this is the specific abdominal pain data with lubiprostone. So lubiprostone isn't as strong. It had a different type of clinical trial endpoint, but this data breaks down the abdominal pain response in patients on lubiprostone versus placebo. So you can see that it did have some effect if you look at a responder definition of at least 30% reduction in abdominal pain compared to baseline, and that is the FDA endpoint. Do you have 30% reduction in pain compared to when you first started the treatment? And in general, there was some benefit with lubiprostone. Linaclotide, if you look at the responder definition, again, 30% reduction in abdominal pain. What you see in a lot of these studies is with placebo, it's around 30%, maybe low 30s, and with the drug, it's around 40%. In linaclotide, it's 48.9%. So you can see that there was a higher therapeutic gain, a difference between linaclotide and placebo. So the linaclotide has been shown to be beneficial in treating abdominal pain and not just helping bowel habits. Now, the reason why they think that linaclotide helps reduce abdominal pain is really based on animal studies, because you cannot do these studies in humans, which is to isolate the sensory nerve that is thought to transmit peripheral nociceptive signals to the spinal cord and to the brain. And by giving linaclotide, it reduced the excitation of those sensory fibers, even though it works predominantly in the small bowel. But we know now that IBS is probably really, from a pathophysiologic standpoint, really due to small bowel as well as colonic disease or pathophysiology. Now, the other key point of linaclotide is the second figure on the right, which is the time it takes to reduce abdominal pain. So even though if you give someone linaclotide, that maybe in the first week or two they start having some reduction in abdominal pain, the maximal effect is at least 6 weeks out. So really between 6, 8, 10 weeks is where you see the maximal effect on pain. And so the reason why that's important is you need to tell the patient that. Because if their expectation, and a lot of treating functional GI patients is establishing realistic expectations. That, I tell you, is a key point. But if they know that, yeah, my bowel habits will get better, but my pain may not get better, or I won't know the maximal effect until I'm at least taking about it for 6 weeks, then I need to take it for that long period of time. Otherwise, if they think it's going to help pain in the next couple days, then they're going to come back to tell you that it's not working. So they just need to understand that. And so that's why I really try to find the right dose for the patient so they can stay on it long enough so I can see if it has an effect or not on their pain and what's the maximal effect. Plecanatide, like I said, is very similar to linaclotide. This is the data from the 2 phase 3 multicenter randomized controlled trials, and this is the abdominal pain responder rate. So again, it's a 30% reduction in abdominal pain, and you can see here that you have a little bit in the upper 20s of placebo response, and you have more in the mid-30s to almost 40%. So again, it's pretty similar to linaclotide. Linaclotide looked a little higher. The patient population is pretty similar, but that was statistically significant. And I really don't think there's that much difference from an abdominal pain perspective in linaclotide and plecanatide. So this is the phase 3 data on tenapanor, and as I mentioned before, and Bill has done these studies, this is a sodium hydrogen exchange inhibitor, so it blocks reabsorption. This showed that it does help not just bowel habits, which is measured as complete spontaneous bowel movement response. So that's having a spontaneous bowel movement, and after the patient has it, they feel like they are completely evacuated. That's a co-primary endpoint for IBS with constipation. But the abdominal pain endpoint is what I told you before. And what you can see here, the placebo had a 33% responder rate for in this study, and tenapanor had a responder rate of 44%, and that was statistically significant. They don't really know why tenapanor helps abdominal pain. One of the areas that they were investigating as a company was seeking if it really improved intestinal permeability, and that was the reason why it helped abdominal pain, but I don't think there's enough definitive data to know that. So for IBS with diarrhea, there's rifaximin. Now, we know that it helps about 40% of people with the overall symptoms, and this is for IBS diarrhea. That's the indication. It's not SIBO indication. The indication is IBS with diarrhea. This is the data from the retreatment trial, where patients got rifaximin 3 times compared to placebo, and you can see the overall response, which is the primary responder definition, and the abdominal pain response. And this had a higher placebo response than what I've shown you previously, so it's 42%. For the abdominal pain response for rifaximin, it was 50%. So you can see that difference is not that high. In general, these patients were treated with rifaximin at the beginning, and if they responded and relapsed, then they were randomized to placebo or rifaximin. So in general, by the time they got to that stage of the retreatment, their symptoms were less severe. And so that you can kind of see that here. So I do feel that patients their abdominal pain can get better as well as their other symptoms, but if you look at the hard data just on abdominal pain response, it's not as impressive. So oxazolone is the mixed opioid antagonist agonist, and this is for IBS with diarrhea. It's a peripherally acting agent. I'm just showing you the data with the percent improvement in abdominal pain. If you look at just the 30% abdominal pain response, it was not statistically significantly different compared to placebo, so it did not reach that endpoint. Now, what they did is they looked at what about if there's a 40% improvement in abdominal pain or a 50% improvement in abdominal pain, which you could argue, and the FDA has argued, might be a little more clinically meaningful. That 30% is probably the lowest you could go. And if you try to look at a 40% improvement or a 50% improvement, oxazolone does separate from placebo in a statistically significant manner. So I think there is some benefit in abdominal pain with this drug, but to me it's not quite as impressive as what we've seen with linaclotide for IBS-C. Elocitron, which I know a lot of people don't use, even though it's been around for 20 years, it's still on a restricted use, but a lot easier to use. This is a 5-HT3 antagonist. That's a serotonin type 3 blocker that works in the lower gut. And this has been a very well-studied drug that has been shown to be beneficial in IBS with diarrhea. Currently, it's available in women with severe IBS diarrhea symptoms who have failed traditional treatment. And this is the data for different doses on a global response, but it also helped abdominal pain. So it definitely can help abdominal pain in the IBS-D patients. For any bowel habit type, we have peppermint capsules. Now, there is some data that an over-the-counter peppermint capsule can be beneficial for IBS. This is a recently published paper in Gastro where they looked at a small intestinal release preparation and a colon preparation. The colon preparation didn't work at all. The small bowel release, it didn't meet its primary endpoint of abdominal pain in the, I think it was 4 weeks or so, or 8 weeks, I can't remember. But when they looked, so you can look on the left, this is the abdominal pain responder. There is kind of a similar percentage responder rate as we've seen in the IBS trials, but this is a smaller group of patients. I think for IBS, since it's heterogeneous, to really have a statistical significance, you need a larger group of subjects. If they recruited 1,000 like a typical phase 3 trial or a couple phase 3 trials, maybe they would be statistically significant. It looks kind of similar to me. But what's interesting on the right side is the IBS severity score, and that's very driven by abdominal pain. And what's interesting is the small bowel release did have a significant benefit when you got out to further along in the trials, which also tells me that maybe in our patients, it takes a while to see abdominal pain response. There's central and peripheral sensitization. I don't think that drugs can really reverse that quite so quickly. I think there's a lot of components that contribute to having a perception of abdominal pain, and it may just take a while to actually have an improvement. So what I did in this table is I summarized data that was reviewed in different studies or studied in different trials. One of them is the Rome working team on neuromodulators, and I would definitely recommend you to go review that. It was reviewed by a group of experts looking at all data and all different functional gastrointestinal pain disorders. And I think their tables are very helpful. But what I want to do in this table is just try to give you some of the data for the different types of neuromodulators and the different disorders. So you have the neuromodulators on the right, you have IBS, functional dyspepsia, and other functional GI disorders. If it's in black, that means there is a statistical benefit on pain response. If it's red, there isn't. So if you look at tricyclics, there's definitely evidence across the board from IBS, functional dyspepsia, and painful esophageal disorders that it helps. For SSRIs, it's really plus minus in IBS. Functional dyspepsia, there was no effect. And a very good trial. And in other functional GI disorders, there was benefit for the non-cardiac chest pain and functional heartburn. So SSRIs look like they're more effective in the esophageal than the lower GI. For SNRIs, it hasn't been studied that well. In IBS, there was only a very small case series in duloxetine. For functional dyspepsia, venlafaxine was not effective. I don't know if you have other SNRIs, if they would be effective, and it was effective in non-cardiac chest pain. The delta ligand agents like pregabalin, it was shown to be effective in IBS in a recent trial, and also functional dyspepsia. Azopyrone, which is like buspirone, was shown to be effective in functional dyspepsia, and a different type of that agent, it wasn't buspirone, was studied in a small study in IBS that showed some benefit. The atypical antipsychotics, like the quetiapine or a drug like that has been shown to have some efficacy in IBS and functional dyspepsia, but these are not large clinical trials. So I just want to kind of summarize this. For tricyclics, the low to modest doses, I usually start at 10, sometimes 25 milligrams. You can go up to 75 milligrams where you're just starting to affect mood. Remember that low doses don't affect mood, so don't give that to them at a low dose if that's your primary goal. It's really meant to help GI symptoms and abdominal pain. You start at a low dose and then you reevaluate in 4 to 6 weeks and you gradually increase the dose to what is efficacious and what doesn't give them so much side effect. You can adjust if you want all the way up to 150 if you're really using it for a mood disorder or for sleep. The secondary amines like disipramine and nortriptyline, they have fewer anticholinergic effects, so you want to think about using that, particularly in the mixed bowel habit pattern or constipation if you're going to use it, or I use it even in functional dyspepsia, I'll use these secondary amines and rather than amitriptyline that has more anticholinergic effect. It helps reduce diarrhea and IBS diarrhea, but it can worsen constipation, IBS-C. For SNRIs, the full dosing is needed to have the benefit for chronic GI pain. I have a lot of patients that want to go on duloxetine at 20 or 30 milligrams, and I know that that's not going to help their pain. You have to usually go up at a higher dose. It has fewer side effects than tricyclics. If you're going to use venlafaxine, you have to go to a higher dose. It has more of a noradrenergic input and effect if you go at a higher dose, and usually you're aiming for like 225. So if you're going to use 150, you may not have the benefit of pain. And I usually use duloxetine. I don't use venlafaxine that much. SSRIs are not that helpful for chronic pain per se, as I said. But if the patient has anxiety or depression, you think it's contributing to their perception of their symptoms and their pain, I think it's a good choice. And I even have used it with patients with bloating, who I think have a lot of anxiety or symptom-related anxiety. And it can help constipation because it's a serotonergic agent, increases serotonin that has a prokinetic effect. So for the pharmacologic treatment of painful functional GI disorders, you need to consider multiple factors that influence abdominal pain in IBS with respect to treatment and drug development. For IBS diarrhea, antispasmodics as needed. I don't think it's great for chronic severe pain. Rifaximin has been shown to have some efficacy in pain. It's not that strong, but it's there. Allosetron, loxatiline shows less benefit for pain than I would say with allosetron. For IBS-C, linaclotide, plecanatide. There's also tegaserod is back out, but it has some restrictions. That's a 5-HT4 partial agonist, and tenapanor have been shown to be beneficial for abdominal pain. I think lubiprostone honestly is a little bit less effective for pain, so I don't really give it to people that have constipation with a lot of predominant pain. For neuromodulators, tricyclic agents are probably the first line that you would go to. Be careful not using the ones with a strong anticholinergic effect because it's sedating and a lot of dry mouth and constipation. SNRIs don't have that much data in functional GI disorders, but has a lot of data to show that it's helpful for chronic pain. And SSRIs, to me, are less effective, and the data shows that for pain. So since we're running out of time, I'm just going to go back to this case, this 52-year-old woman that was referred to a GI for this chronic abdominal pain and has a lot of tried some opioids, antispasmodics, tricyclics, had difficulty tolerating them, had a lot of GI workup as well, and has some life stressors. So I just wanted to ask the panel on patients with chronic pain, and it could be different types of disorders, but we talked about if they want more diagnostic tests, but I think that the audience would like to know, and I don't know who wants to volunteer for this, when you're trying to explain these as brain-gut disorders, how do you explain it? What do you think is a good way of explaining that to patients? Does someone want to try first?
I can start and then you can go on. I have definitely tried to start with some very long, lengthy explanation with patients, and I've done that, but usually when I do that, I tend to lose them. So instead of kind of just explaining the brain-gut axis, I try to first figure out what is preventing them from necessarily understanding it or more likely believing it. So for example, sometimes patients really get hung up on this concept of pain that they can't see on a CT scan or, a lab test. And so for those people, my entrance into the brain-gut is headaches. Migraine headaches. You can have headaches, you believe in headaches, but you're not going to see those on a CT scan. For other patients, I may start with, for example, the patient here who has this history of verbal or sexual abuse. So sometimes patients will, become tearful in the office, and they'll bring that up. And if they're bringing that up, that's probably because they think that there is a link. So I may use that as an entry point to explain to them how exactly their history of abuse or their current life events that may be triggering that, how that could be playing. So that's kind of how I approach it. As far as the details, maybe I'll...
Does anyone else want to add how you explain it? Because I do think that people want to know that question.
I think that it really does vary on the patient. And so I do exactly what you do. I try to figure out how I think it may be operative so that I can mirror what they've told me. And so if they tell me about their stress-associated symptoms, then I may explain it, how the brain-gut axis may explain those symptoms. And so I'll often say, the gut works on its own. If we detach it from the brain, it can do all of the things that it needs to do just fine, but it's not going to be modulated, and it's not going to have the responses that we have when we're hungry. It's not going to have the responses that we have when we remember things. It's not going to have the butterflies in the stomach when we're excited. It's not going to have that response that you may have when you're right before a big test and you feel like your stomach is upset or you need to run to the bathroom. Those are the brain-gut responses, and almost all of us have had one of those. And so I try to listen to where that may come out.
Yeah, I think that's really important. I obviously give a much more scientific explanation, but I think that relating it back to the patient is really important. So Bill, how do you explain how a neuromodulator works for their symptoms and why they should take that?
So I use a lot of specific examples when I'm talking to patients that I think suffer with these disorders of brain-gut interaction. And I definitely use the one which I think most people can relate to of, have you had a stressful event where you've developed GI symptoms, abdominal pain or diarrhea, or known somebody? Almost everybody at least knows somebody that they had problems with GI symptoms before an athletic event, before a travel, before taking an exam. So they understand that and can relate to that. And what I then go on to explain is that some of that is related to differences in the hardwiring. So again, trying to provide a very concrete example. In the hardwiring that's responsible for that interaction between the brain in your head and the brain in your GI tract. And subsequently, the way that your GI tract functions and senses different things that are occurring in response to just normal daily activities. So, we all encounter stress on an everyday basis. Most of us don't develop abdominal pain or diarrhea as a consequence. We all eat food every day. Most of us don't necessarily develop problems in response to that. So something is different in terms of the hardwiring of patients with IBS. And so then I go on to explain that the concept behind these neuromodulators is to alter or modulate or normalize that abnormality in the hardwiring that leads to these abnormalities in brain-gut dysregulation. And I think if you do it in those terms, most of the time the patients actually will understand that fairly well and be accepting of it. Because if you'll notice in there, nowhere was I talking about stress or anxiety as being the primary provoker. Certainly do I not talk about that you have a mental illness that's really driving, because I think that's the big concern on the part of patients. The patients feel like what we're saying is it's all in your head and basically you're crazy and this is all a GI manifestation of psychiatric disease. And while those things can certainly make things worse, I don't think those are the primary drivers in IBS, at least in most cases.
Yeah, I think the key thing in chronic abdominal pain specifically is to also explain why it's not getting better as quickly as you expect it to. So we may give you a medicine, it's like, well, why is it when I take Norco, I feel better, though often people don't feel that much better with opiates, but I feel better when I take that. And I explain, this is where one of the times I do bring in some of the research, and I say we know by looking at the brains of people who have chronic pain, whether it's headache or IBS or chronic low back pain, that there are parts of the brain that have remodeled, that have actually changed, and that change took a long time, usually months and months, and for some people it could be decades. And so we're giving medication that we also have to give time. The brain, if it's going to remodel to look more like a brain of someone without pain, it may take some time.
Yeah, I also remind patients that the signal has to get to the brain for them to actually perceive they have pain. So they can't, it's not just, it can't just stay in the gut, right? It has to get to the brain for any of us to feel anything. And then I often, and it depends probably on the level that I perceive the patient wants to hear, but I do explain that we have our own inherent pain inhibitory pathways from the brain to suppress pain. We all have that. And, it's the opioid system, the noradrenergic, the serotonergic, so they understand why I'm giving them an SNRI. So why I'm working on the serotonin, the noradrenergic system, that you're trying to enhance the activation of them. So that's kind of a very simplified, but otherwise they're kind of wondering why are you giving those kind of agents. Lynn, do you want to say something?
So just for some of my patients, I can't be that complex for. So kind of just for basic advice, maybe something that's worked well for me to explain visceral hypersensitivity is to give them an analogy that they may understand. So for example, if any of us were to eat an entire pizza or a 6-pack of Diet Coke, we would have a lot of gas production, gas, bloating, abdominal pain. It wouldn't be weird for us to be on the toilet for an hour after doing that. And then branching to visceral hypersensitivity as you don't need that whole pizza. You don't need a 6-pack of Diet Coke. You just need one slice of pizza. And then sometimes for the neuromodulators, to explain that more simply, I'll say something like, there's usually a gate, there's some sort of blockage so that not every single signal that your body is sending to your brain needs to get to conscious awareness. You don't need to know what your heart is doing or your right colon or your left colon. But sometimes that gate is malfunctioning, it's open, it's not working. And so all of a sudden, all these extra signals are getting to your brain. And then the stress response is we have this exaggerated response to all these incoming threats. So that's sometimes how I describe it more simply.
Okay, I really wanted to ask you guys how you use the algorithm for neuromodulators, but we're out of time and we got to go to lunch. But we're going to be back after lunch, and we have questions here, and I'm going to try to get it to them at the Q&A. If any of you see us and you want to ask us one of these questions, if we can't get to, feel free. Tricia, what time should people be back?